Welcome to the Argos Cardiac Output Monitor training module. In this module, you will learn proper setup of the Argos monitor, when to use the Argos monitor in clinical practice, how to apply hemodynamic information obtained by the Argos Cardiac Output Monitor, discuss the difference between pressure and flow, how to properly shut off the Argos monitor, and how to clean the Argos monitor. Let's begin with what makes the Argos different than other cardiac output monitors. First, it's easy to set up and use. There is a single cable connection and intuitive user interface. There are no additional transducers or arterial line setups required. This is a dry setup. Second, it's cost-effective. There are no disposables. And third, it is consistently accurate via the MBA algorithm. Radia Medical's proprietary multi-beat algorithm analyzes multiple heartbeats at a time from the arterial blood pressure waveform, unlike other single-beat hemodynamic monitors that only analyze one heartbeat at a time. The MBA algorithm uses multiple heartbeats to continuously model the patient's vascular dynamics to provide a significantly more accurate hemodynamic profile. Using a single reusable cable connecting the patient's existing arterial line to the bedside monitor, within 1 minute you will get a full hemodynamic profile using the Argos. Because this is a dry setup, there is no additional transducer needed and no need to reconfigure the arterial pressure lines in order to hook up the Argos to the patient. Simply connect the Argos to your existing bedside monitor and view your hemodynamic profile within minutes. The Argos is compatible with all major vital sign monitors, has 0 proprietary connections or compatibility concerns, has an intuitive user interface, requires no calibration, and easily implements into a nurse's workflow as there is little to no training needed to use the monitor. Here are the simplified user setup and implementation steps to begin using the Argos Cardiac Output Monitor. A more in-depth step-by-step tutorial will follow. Step 1. Power on the Argos. Press and hold the power button for a full 5 seconds until the light turns blue. The power button is located on the side of the monitor. Be patient, the Argos does take a minute to boot up. Note, powering off the Argos is done by going to the main menu on the home screen and selecting Shut Down. Step 2. While the Argos is booting up, connect one end of the black Philips analog cable to the output port located on the side of the Argos monitor, underneath the power button, and the other end to the Philips press out or pressure out module port, as shown here. Step 3. Enter patient demographic data. Once the Argos is booted up, using the touchscreen, enter the patient ID, gender, age, weight, and height. Be sure to choose the appropriate unit of measure, either metric or imperial. Then press Save. Please use the birth sex of the patient as the gender, as this can affect the arterial compliance calculation. You may also select Use Previous Patient if you have a previous patient that you are returning to monitor. Step 4. Select Bedside Monitor on Argos. Select Bedside Monitor as the blood pressure signal source and press Next. The Argos Cardiac Output Monitor is now ready to receive the blood pressure signal from the Philips bedside monitor. Please note, you will almost always select Bedside Monitor. The transducer input is rarely used, and then only if you have the appropriate accessories from Radia Medical. Step 5. Transfer arterial blood pressure to Argos on Philips bedside monitor. This step will be required only if you are changing out the Philips ABP module. In order to transfer the arterial blood pressure signal to Argos, the user must discontinue ABP on ABP1 and select ABP from Press Out module. This will allow you to see the ABP on the Philips module via Argos. Note, on the bedside monitor, a pop-up should have appeared automatically when the black cable was connected to the Argos and Philips Press Out module. Step 6. Level and zero the arterial line. Leveling and zeroing of the arterial line should be done per hospital policy and will only be required if changing out the Phillips ABP press-out module. Level and zero the arterial line following the usual steps per hospital policy. There is no need to touch anything on the Argos cardiac output monitor while you are leveling and zeroing your arterial line. Once your arterial line is leveled and zeroed, you are ready to begin using the Argos. Change the displayed parameters on the Argos monitor to reflect your preference to see the patient's full perfusion profile. Step 7. Verify ABP on Argos. To verify the ABP on the Argos cardiac output monitor, select any parameter box from the right-hand side of the touchscreen. Select Parameter Settings at the top of the screen. In the parameter box with the down arrow, scroll down via the drop-down menu and select Blood Pressure. Press Save and the screen will automatically return to the main display. Please note that the ABP waveform will still be displayed on the Philips bedside monitor throughout this process. After you verify the blood pressure waveform on the Argos, you are ready to begin monitoring. Step 8. Change displayed parameters. There are 3 parameter sections on the Argos. We recommend changing the displayed parameters to SV, SVI, SVR, SVRI, and CO, CI. To do this, touch any of the parameter fields on the right-hand side of the touchscreen. Press the drop-down menu to see a list of available parameters. Scroll to choose the desired parameter. Touch Color to change the color of the parameter or trend. Touch Save to confirm these changes. We recommend that after you verify that the ABP has been pulled over from the Philips monitor to the Argos, you change the displayed parameters to reflect the full perfusion profile. For example, stroke volume index for preload, systemic vascular resistance or systemic vascular resistance indexed for afterload, and cardiac output cardiac index for contractility. This setup with the color coding makes it simple to quickly assess your patient's hemodynamic status. Clinical application. Now that you know how to set up the Argos cardiac output monitor, let's discuss when you would typically implement monitoring and how to apply the hemodynamic parameters at the bedside. The Argos cardiac output monitor displays all the hemodynamic parameters you need to manage your patient's perfusion status. Let's talk a little more about perfusion and how to apply the hemodynamic profile at the bedside. As you are all aware, blood pressure tells you about pressure. It doesn't tell you about how much blood is flowing to the vital organs. Comprehensively monitoring hemodynamics allows clinicians to manage both pressure and flow. The relationship between pressure and flow is MAP minus CVP is equal to CO times SVR, where MAP is the mean arterial pressure, CVP is the central venous pressure, CO is the cardiac output or flow, and SVR is the systemic vascular resistance. MAP and cardiac output sometimes follow each other. This typically occurs when SVR is not changing, which leads to the common misconception that managing pressure or MAP is the same as managing flow or cardiac output or stroke volume. This is what other cardiac output monitors often do. However, in most critically ill patients, pressure and flow are decoupled due to changes in SVR because of the use of pressors or vasoactive agents naturally produced inside the human body. That is why, to determine flow, the MBA, or multi-beat analysis algorithm, was designed to accurately detect changes in SVR. Let's look at what the literature says about pressure and flow. In 1944, researchers exsanguinated, or bled, a group of Irish medical students until they fainted. Now, ethical concerns aside here, the underlying physiology demonstrates that pressure does not equal flow, and that blood pressure is in fact a lagging indicator that a developing perfusion deficit is occurring. As you can see in this graphic, Minutes after the subjects start bleeding, cardiac output begins to fall. We expect to see the heart rate climb to compensate, but notice blood pressure doesn't change until the subjects faint. It's also well documented in the literature that by the time patients are hypotensive, they've already been compensating for a perfusion deficit we couldn't see without looking at cardiac output. This is part of the problem of perfusion. We cannot see the earliest clinical signs that a patient has a perfusion deficit without continuous cardiac output monitoring. In essence, it allows us to see around the corner. Now that we understand some main reasons why we should be using the Argos cardiac output monitor, let's dive into more detail. Typically in medicine, we measure perfusion with blood pressure, but blood pressure is just that, a pressure measurement. What we really want to know is about the blood flow. The fact that you have an adequate blood pressure does not mean you have adequate flow, because pressure doesn't equal flow. Now, perfusion comes down to oxygen delivery, and the components of the formula for oxygen delivery are adequate hemoglobin, or oxygen carrying capacity, good oxygen saturation, or adequate oxygen in the body, and reasonable cardiac output, or forward flow of that oxygenated blood. For the purposes of this conversation, we're going to focus on cardiac output as it's the key measure of blood flow. The formula for cardiac output is equal to heart rate times stroke volume. Now let's define each of these components of the formula. Heart rate is how fast or slow the heart beats every minute. Stroke volume is the amount of blood in milliliters ejected from the left ventricle with each heartbeat. Cardiac output is the amount of blood in liters pumped out by the heart every minute. Rarely do we increase heart rate to get an improvement in our patient's perfusion. What we do have at our disposal to try and optimize perfusion is stroke volume. If we can optimize the stroke volume, we can improve overall cardiac output. There are three things working in concert that make up a person's cardiac output, and they are preload, afterload, and contractility. To keep it simple, think of it like this. Essentially, we have three pathways in the body to help improve perfusion and/or correct a deficit, such as when we have evidence of a perfusion problem like hypotension, tachycardia, oliguria, etc. Now let's name those pathways preload, afterload, and contractility. The first pathway is preload, or volume. The preload of the heart is the amount of volume in the ventricle prior to each systolic ejection, or heartbeat. The parameters that correspond the closest with the preload pathway are stroke volume and stroke volume index. You can think V for volume. Now remember that our index numbers are simply adjusted for body size. What we really want to know is if we give this patient additional preload or fluid, can the ventricle stretch to accept it, and can the heart then push it forward, thereby increasing the overall cardiac output? We can actually assess if the patient is preload responsive or volume responsive or not by performing a small fluid challenge and watching the response of stroke volume. This is called a dynamic assessment. The tricky part is that we won't know if that patient is a fluid responder or not unless we check. We know that from the data, we have a 50-50 shot of getting the fluid answer right without performing a dynamic assessment. It's essentially like flipping a coin. In the absence of the ability to do a dynamic assessment, trending stroke volume or stroke volume index is a solid way to determine if fluid is improving overall cardiac output. A stroke volume that is increasing during fluid administration indicates that the patient is able to push that fluid forward. A stroke volume that begins to plateau or decline during fluid administration should raise questions about the value of further fluid at that time. Remember, just because it doesn't look like fluid is what the patient needs at that moment in time doesn't mean that the patient will remain fluid unresponsive. That's why trending SV and SVI can be helpful, because if your stroke volume or stroke volume index starts to decline during your shift and you're not giving a fluid bolus, this could indicate your patient is potentially developing a perfusion problem. Our second pathway is afterload or resistance. This is the vessel pathway. It's the amount of resistance the heart must pump against in order to pump blood out to the body. This resistance is after the heart and working with downstream blood flow. Hence, it's called afterload. The parameters that correspond with afterload are SVR and SVRI, or systemic vascular resistance and systemic vascular resistance indexed. Think R for resistance. Typically, one can increase resistance by giving a vasopressor. In order to decrease resistance, one can either reduce the amount of vasopressor or give a vasodilator. The important thing to remember is that the lower the SVR number, the more vasodilated or wide open the vasculature is, and the higher the number, the more vasoconstricted or smaller the vessel opening is. And our third pathway is contractility, or the pump pathway. Contractility is the strength of the heart's contraction or squeeze. The parameters that correspond with contractility on the monitor are cardiac output and cardiac index. You can think C for contractility. Cardiac index is the accepted measurement of contractility. If an increase in contractility or squeeze is required, an inotrope may be given if you've determined fluid isn't helping. In order to optimize end organ perfusion, preload, afterload, and contractility should be optimized and can be done via SV, SVR, and CO manipulation. However, if low cardiac output continues after reviewing all of these parameters, you might want to consider further diagnostic tests like an echo, 12-lead EKG, or full cardiac workup. Now let's relate this back to the Argos cardiac output monitor one more time. Here you see a version of the recommended configuration of the Argos, where preload is represented with SVI, which is blue, like water, indicating volume. Afterload is represented with SVRI, which is purple for pressor, indicating resistance. And contractility is represented with CI, which is yellow like a lemon that you would squeeze for its juice, indicating the squeeze of the heart. We're always trying to maximize perfusion in hemodynamically unstable patients. Generally, we approach hemodynamic instability with fluids first, based on clinical judgment, but we really never know for sure if a patient needs fluid, a pressor, or some kind of inotropic support unless we can see a full hemodynamic profile. Numerous studies have shown that hemodynamic guided fluid therapy can reduce complications by up to 50% and shorten ICU length of stay by up to 1 to 2 days. We now know that about 50% of hemodynamically unstable patients are not fluid responders. In other words, cardiac output will not improve in response to fluid administration. This creates a sense of clinical urgency around fluids because we also know that over and under resuscitation causes short and long-term complications in patients. The old way of loading patients up with fluids only to then take them off through diuresis is no longer the recommended standard. We genuinely didn't know that fluid overload would impact the kidneys, the gut, the heart, the lungs as severely as it does, and that diuresing the patient does not reverse those impacts. This means we have to improve our fluid management strategy. Every single patient has an individualized volume need. Most clinicians agree with this statement based on the overwhelming evidence that there are serious consequences with both over and under resuscitation because of the cost of cardiac output monitoring, the risk associated with the invasiveness of the pulmonary artery catheter, concerns about accuracy and less invasive monitors, and the high cost of disposables. Titrating fluids to stroke volume or stroke volume index has been difficult to implement in clinical practice. Until now. We give fluid when a patient has a low blood pressure, but if pressure doesn't equal flow, and if fluid only works half the time to improve cardiac output, then now more than ever, we need to be looking at other options for improving perfusion. This includes afterload and contractility. Again, how do you look at these perfusion markers without an advanced hemodynamic monitor that will accurately reflect stroke volume, systemic vascular resistance, and cardiac output in the face of vascular tone changes that also has a low risk profile and won't bankrupt your bottom line? The Argos is the answer and is an ideal way to continuously monitor the full perfusion profile of the patient. The 50% statistic. Numerous studies have proven that only about 50% of hemodynamically unstable patients will increase their cardiac output in response to fluids. This means that when our patients are hypotensive, fluid is only helping them about half the time. Being able to view other perfusion parameters like systemic vascular resistance and cardiac index, in addition to stroke volume index, allows nurses and providers to zero in on which determinant of flow to target with medication. For reference, here is a table of normal values for commonly used hemodynamic parameters. When implementing the Argos into clinical workflow, consider the following. This is the Argos clinical logic. Does my patient have an arterial line? If yes, then connect the Argos to assist in determining which contributor of flow you may need to address to stabilize the patient. It could be all three. Is my patient hemodynamically unstable? Consider an arterial line placement to get the full perfusion picture. Is my patient headed to surgery, and will I be placing an arterial line? If yes, hook up the Argos to manage the full perfusion picture. How it works, the MBA. Other pulse contour technologies do not accurately track hemodynamic parameters when SVR is changing, during arrhythmias, or when cardiac output is low. Clinically, this is problematic. Radia uniquely offers an algorithm that can accurately trend changes in vasomotor tone, thus providing more accurate hemodynamic values in a wide variety of clinical conditions. How is this done? Radia's MBA algorithm, or multi-beat analysis algorithm, analyzes multiple heartbeats from the blood pressure signal to accurately model the patient's circulation. This provides the ability to accurately track changes in vasomotor tone as measured by the SVR parameter. Further, analysis over multiple heartbeats allows for consistent accuracy even when consecutive heartbeats are irregular, as happens during arrhythmias. The algorithm is patient-specific and takes into account the age, height, weight, and gender of the patient, in addition to their unique blood pressure waveform. The MBA algorithm provides an updated cardiac output, stroke volume, and systemic vascular resistance every 5 seconds by analysis of the most recent 20 seconds of the blood pressure waveform. Radia recently had a publication regarding the performance of the MBA algorithm in the presence of arrhythmias, which showed that hemodynamics can be accurately monitored in cardiac surgery patients where arrhythmias are commonplace. This is important because most, if not all, of the other cardiac output monitors currently on the market have limited accuracy when patients slip into arrhythmias like tachycardia and atrial fibrillation. In summary, here are some of the important features of the Argos monitor. There is a one-cable connection. It's plug and play. There are no additional transducers or arterial line setups required. There are 0 disposables. There is one screen for everything you need to see. There are customizable parameter colors. There are no audible alarms, just a simple visual status bar. And there are simple event flags to mark interventions. In regards to maintenance and care, the Argos cardiac output monitor may be cleaned with any hospital-approved disinfectant wipes, including bleach wipes. If a white film appears on the Argos screen after the appropriate dwell time, take a slightly damp paper towel or cloth and gently wipe the screen. The Argos should be plugged in at all times, even when not in use. The battery life is 30 minutes when charged. Always power down the Argos by going to the main menu at the bottom left of the screen and selecting the shutdown option. The Argos is a cost-effective, consistently accurate cardiac output monitor without compromise. Thank you for your time and attention during this training module.